Welcome back. Today we'll be discussing hematologic disorders. So, let's see what's bloody going on. I couldn't help myself. All right. So, first thing we look at, protein electrophoresis. So when you talk about, the bloodstream and what's in there, there are many different components. And one of them is proteins. And there's different protein structures. So we just have a couple listed here, but albumin, fibrinogen, okay, your different globulins, which would be like your IgG, IgM, IgA. Well, technically not IgA, okay? IgE, all right? And then there are other structures which are from like the hemoglobin structures, the alpha 1 helix, alpha 2, beta 1, beta 2, all of that can be in there as well. So the value here is when you talk about in certain diseases, for example, like if someone has liver cirrhosis. Well, the liver is what makes albumin. So we should see like albumin levels are tanked. Albumin is needed to help with osmotic or oncotic pressure along with other solute. So maintaining fluids in the bloodstream instead of it excessively pushing out into the tissue. And also for your non-polar lipophilic substances, they need to get around your bloodstream somehow, and the fat doesn't mix in water, if you will. And so that's where, albumin will bind to it and work as a transporter. That's another reason, okay? And then in certain diseases like multiple myeloma, we can see spikes. So this can help us identify an illness as well. Generating blood, erythropoiesis. You need B12, you need folic acid, okay? So this is where stomach comes into play. We don't think about this sometimes, but the parietal cell in your stomach creates intrinsic factor. Intrinsic factor must bind to B12 in order to be absorbed. So in reality, there's like a big push lately. Oh, everyone needs B12 shots, B12 shots. It's not exactly. Really, the only people that need B12 shots are people that have had stomach bypass or pernicious anemia, which in those two cases, they're not producing intrinsic factor, and so they cannot absorb it. The rest of the population, if you somehow have a B12 shortage, really the only people that have B12 shortages because of diet are vegans, because they're not getting it from like dairy products, animal products, stuff like that. Outside of that, B12 shortage, pretty rare, okay? And realistically, if you have a B12 deficiency, you would have a macrocytic anemia. Your red blood cells would be large, okay? That's when there's that abnormality. Folate or folic acid, the big part here that it's needed for is also producing DNA. And so that is crucial, especially like in organogenesis period of pregnancy, very early on in pregnancy. So that's why prenatal vitamins are heavy in these structures. When there are deficiencies, we see glossitis, swelling of the like tongue, skin changes, and whatnot. Okay. And flattening of the villi, that's in the gut. That's what we're referencing. Red blood cells, they can't repair themselves. They don't have a nucleus, right? So eventually they get damaged or they kind of time out, fizzle out, and we got to get rid of them. And roughly that time period is 120 days plus or minus a week. Okay, so we generate red blood cells, they go around 120 days, and then eventually we start to break them down. So macrophages will break them up, especially in like the spleen, and we get the globin and the heme products. Our body doesn't want to waste stuff. So the globin, it's a protein structure. We'll just break it down into the individual amino acids, recycle it, and use it for something else. Make more red blood cells, make IgG, whatever we want. Make muscle, okay? The heme we need to break down, and it's got two subcomponents. One is the biliverdin, and two is the iron. So this Fe3+. So we can recycle the iron. We don't want to lose that, and we'll use it to make more red blood cells. The biliverdin is converted to bilirubin. It's conjugated using the liver, and then it's sent out in bile. Some of it will be reabsorbed, and then it leaves as urobilin in the kidney. Okay, so this is what gives our stool its color. If it's absent, they refer to the stool as clay-colored stools. And in part, it gives some of your urine its coloring. Okay. Cyanosis, so this is bluing of the skin. Typically, we talk about this as an abnormal amount of methemoglobin. So the issue here is we go from this ferric to ferrous, or actually ferrous to ferric in excessive amounts, and it's due to some interruption. So like this guy here, he's very famous. I think his name was Paul Carrison with a K. I'm pretty sure it's Paul Carrison if I remember correctly. This smart guy started taking colloidal silver and rubbing silver all over his body, and it interrupted this process. Okay, heavy metal poisoning, that's what that is. All right, certain drugs like benzocaine, so this is like one of like the lidocaine family. Okay, so like it's a numbing agent. For example, dapsone is a drug that is used in TB and I think leprosy, if I remember correctly, and it can trigger this. Okay, so it's just this abnormal amount, not good. Okay, so you can stop the drug. They can do transfusions. I think even putting them in a hyperbaric chamber can help with the conversion. Okay? Anemia. There's all kinds of anemia. All right. There is macrocytic. The cell is too large and not functioning properly. There is microcytic. It is tiny and not functioning properly. Normochromic means normal color. Hypochromic, it's lacking color. There are anemias because iron deficiencies. There's anemia because of bleeding. There's anemia because of mechanical destruction. There are all types of different anemia. Do not ever assume it is just iron. Iron anemia, probable in a woman, not probable in a male. Okay, typically with females, it's due to menstruation. They're constantly they're losing that iron over time. They need to increase iron in their diet. So it's funny, you look at like a multivitamin for women, it has iron. For males, it does not. Okay. Excessive iron intake causes like constipation, for example, causes fatigue. So don't just willy-nilly take iron. You need blood work to figure out if you need it. So macrocytic, normochromic. So these are these very large cells, red blood cells. I mean, look next to a white blood cell right here, this lymphocyte. That is a huge, huge cell. It should not be that big. Okay, so here's like your vitamin B12 deficiency, and you can see where it's at, and that's why I said like vegans can become deficient. Okay, folic acid also causes a macrocytic normochromic, so large but normal coloring, and then microcytic hypochromic. Here's your iron deficiency. Okay, and these are tiny compared to the white blood cell. Okay, not very functional. Couple terms here: mean corpuscle volume. So we're just talking about the average size of the red blood cells. MHC. This is the percentage of hemoglobin to red blood cells, and then MCHC, hemoglobin to hematocrit. Okay. So these levels can direct us to which anemia the person has. That's where this information comes into play, as well as checking like iron carriers and whatnot and identifying the anemia that way. So if someone has an iron deficiency, there's a couple different symptoms here. This one is pretty unique. The oh my lord. Onchyosis, okay? Spoon-shaped nails, right? That is one of the telltale signs. The nail it literally divots down. The nails fracture very easily. They're very dry. The fatigue, okay? A lot of those are telltale signs. Sideroblastic, here's an issue where they can't incorporate iron, and so you get this like stippling around the cells, and so you see it in sideroblasts in the bone marrow. That's where it's usually identified, and really it's just they can't incorporate the iron into their hemoglobin. They can't generate the structure properly. All right, your bone marrow. So this is where we generate our red blood cells, white blood cells. So this is your normal bone marrow, nice and dense and full. Sickle cell, you can see the cell sickling already. Okay, and then aplastic anemia. There's nothing. This is very bad. Okay. Different things can damage the bone marrow. Genetics, obviously, like sickle cell, pernicious anemia, not so, aplastic anemia. I don't know why I said pernicious anemia. Aplastic anemia. It can be idiopathic. It can just happen. There are certain medications that can trigger it. And then like radiation therapy, chemo, stuff like that can trigger it as well. They don't have an immune system if this happens. So they are taking daily antibiotics. All right. They have to take them daily at that point to protect themselves. Jaundice. Really, the whole problem here is either we're lysing. So if you remember on the last slide, hemolytic anemia. So something is mechanically destroying it, or the red blood cells are fragile. They don't last like they should, and they just spontaneously lyse. Malaria, for example, infecting the red blood cells, destroying them. These are hemolytic anemias. The problem here is as we start to break down the hemoglobin, there's too much bilirubin for our system to deal with. Or the liver is impaired. So like cirrhosis, okay? Damage to the liver. And so the bilirubin starts to accumulate in the body. As it accumulates in the body, we see this yellowing of the skin, yellowing of the whites of the eyes, and it can cause lots of damage in newborn. It can cause brain damage, for example. So it tends to we need to deal with it. We need to get that process corrected if possible. And it also causes like itching, so it's not a fun process. Myeloproliferative disorders, these are excessive expansions. So here you can see there's way too many red blood cells. There's all kinds of different myeloproliferative disorders. They can be of different lineages. It doesn't have to be of all cells. If there is something wrong with the cell, we tend to see an excess production because the body wants functionality and it's not getting that functionality. So it's like, make more. It thinks there's a shortage. It doesn't understand they're non-functional. It just thinks that there's a shortage. And so it's like, make more, make more, make more. And once again, here you see this like histamine release due to excessive production of these cells, and they can get this itchiness as well. And, the other real big thing is you start to look at when you have polycythemia, so this is like all the cell lineages increasing, is what does that do to our system? It becomes thick. It's viscous. So blood flow starts to slow. If blood is stagnant, we get clotting. We get strokes, DVTs, pulmonary embolisms, all kinds of different problems. So this is dangerous. It could be medically induced. Like if someone's taking erythropoietin, EPO, and they're taking excessive amounts, they will have a polycythemia. Okay, and sometimes it can be idiopathic. It just happens, right? If there's a dysfunctional cell like leukemia, you can have a polycythemia because the cell isn't functioning. We're just making more and more and more. Hereditary hemochromatosis, so this is just the excess amount of iron buildup, and so they're excessively absorbing iron, and it starts to deposit in the tissues. It destroys tissues, like this liver, you can see all this spotting on it. It can deposit in the pancreas. They can end up with like diabetes. It deposits in the skin. They get this bronzing of the skin. And once again, it can be due to other disorders. Like I have a friend that has a blood disorder, and he has this issue where the red blood cells lyse spontaneously. There's a defect in the hemoglobin, and they lyse after about 60 days. And so he has this excess iron in his body now, and he has the bronzing of the skin. He has jaundice on top of that. So he takes a medication, a chelating medication that he drinks every day, and it binds to the iron and gets it to where he can excrete it in his urine, and he can pass it out that way to help prevent destruction of tissue, organs, all that good stuff. And the name of that disorder, it's thalassemia major. If you were interested in looking it up, it's thalassemia major. All right, your white blood cells, the normal count between 4,500 to 11,000. You'll see different ranges according to what labs you're looking at. And, if it drops too low, you can get infection easily, okay? Because your white blood cells aren't there to protect you. We can see increases, so like EBV, Epstein-Barr virus, so it infects them, and so we get this mononucleosis, we get tons of them. If you have a bacterial infection, we should see neutrophils rise. If you have eosinophil increase, that means you probably have allergies. And then lymphocytes, this would be if some type of viral infection is what we tend to think about. Okay? So they all have a purpose. It's a unique purpose. And so when we do a differential on blood work and we look at these elevated levels or decreased levels, it helps give us direction on what is going on with the patient. Okay? If I see lymphocytes are tanked, non-existent, now we start to think like HIV. Something's wiping them out. Okay? Leukemia, there's 4 basic types, and then there are subtypes within this. But you have your acute lymphocytic leukemia, or ALL, acute myelogenous leukemia, AML, chronic myelogenous leukemia, and then chronic lymphocytic leukemia. Now, they tend to happen in these age groups, but it's not a must. It is not a absolute, okay? But these are the most common age groups that you see them in. CML, this 922 translocation, what's called the Philadelphia chromosome, is seen in a majority of the cases. So this is this genetic disturbance very early on in life, and then it manifests at CML later in life. Okay? CLL, this one, there's not really much treatment for. The first 3, there are treatment options. CLL, there really isn't much, but they tend to live a long time with this, like 20 years. And it's just a slow-moving leukemia. So, clinical manifestations. Well, if you don't have functionality in them, infection, right? And if it's increasing like we see here, I mean, these are monstrous. The amounts and the size, it's going to be viscosity again. So now we go back to DVTs, embolisms, all that fun stuff. Right? Lymphatic system, you need your lymphatics because your blood vessels push out more pressure than what's pulled back in by oncotic or osmotic pressure. We need to do that to perfuse the tissue. So we need a drainage system. That's where lymphatics come into play. We also need it as a superficial point to, if we get like a cut or something and bacteria gets in there, it's like a warning system, because the lymphatics go through your lymphoids, okay, your lymph tissue, and it is a point where there's a lot of white blood cells. So it's kind of like a checkpoint before we enter the body into the bloodstream. And so that can help warn us or get our systems going before it becomes a dire situation. Lymphadenopathy, so this is a swelling of the tissue. Many different causations. The one, I have here, Hodgkin's lymphoma. So there's those Reed-Sternberg cells again. This is a malignancy, okay? It can be due to compression. So when people gain a lot of weight, for example, it compresses the lymphatics, lymphedema. It could be because surgery. We removed breast tissue, and we removed the lymph tissue or the lymphoids in the axilla region in the armpit. Well, there's no flow out from the arm, and they'll get swelling in the arm. This kid is probably cat scratch fever. If I remember correctly, that's why I chose that picture, because it's a neat thing. There's a bacteria that cats tend to carry, or the fleas of cats, and so they'll scratch you or the flea bites you, and the bacteria is replicating in the lymphoid tissue right there, the lymph nodes, and the swelling. They just take a antibiotic and it'll clear, but fun times. Multiple myeloma, so it's a B-cell cancer. They produce tons of IgG, like when the first image we were looking at. So when we do, looking at the protein analysis, we can identify that would direct us. These Bence-Jones proteins are an abnormality. All of this causes like hyperviscosity, and then it acts. The interesting part here is, this excess interleukin 6 that is released, it increases osteoclasts. It eats the bones. You see all the little like translucent areas in the skull imaging of the x-ray? That's just the osteoclasts over consuming the bone. A buddy of mine, his dog, just one day fell over, and he's like, what the heck? And the dog couldn't stand on its leg anymore. It takes it in. It had multiple myeloma. It had eaten the bone so much that while the dog's standing there under his own weight, the bone just fractured. Okay? And there wasn't much to do at that point, unfortunately. Hypersplenism, so just a massive spleen, okay? And to give you an idea of size difference, there's the liver, normal. Spleen should not be that big. Spleen should be like a quarter of the size of the liver, okay, for comparison size. And there's lots of causations here. It's overactive. It just starts consuming things. It can rupture. Like EBV is a common time. Mono. When patients have mono, they'll have this hypersplenism. And you got to let them heal, let it reduce, or it can rupture easily. So it can overconsume things, so it can cause these anemias, thrombocytopenia, so platelets are low, leukopenia. You can trap them in there and whatnot, so sometimes it just has to be removed in that situation. Thrombocytopenia, so this is a lack of platelets. They can develop it spontaneously. Heparin can cause it, so this is HIT, heparin-induced thrombocytopenia. Heparin is a faster acting blood thinner, anticoagulant, so they use it sometimes until other drugs that they're going to use to continue with therapy for anticoagulation come online. Sometimes, surgery, they'll do it to thin the blood because the person isn't moving around, so they don't develop stagnation of blood and clots and whatnot. Okay? The problem is they start to hemorrhage, potentially. And we can see hemorrhaging under the skin. So this is early on. This is petechiae. They're very tiny. As they start to get larger and start to coalesce, that's purpura. And then ecchymosis are these very large bruising areas. Okay? So certain illnesses can cause this. You tend to see these last two, especially with meningococcal infections. So meningitis. Meningitis, for example. Virchow's triad, it's this trifecta. They have hypercoagulability, so like a polycythemia. Hemodynamic changes, stasis, turbulence, and when you get a plaque buildup in a vessel, damage to the vessel, or stasis, they're not moving around a lot. And then endothelial injury or dysfunction. So like the plaque buildup as well, direct damage, cutting it, something like that. When you get these three, you are very high increased risk of thrombosis, okay? Throwing a clot. right there. That's a giant clot, okay? That is a killer. It's right here, okay? So what's happening here, this is the pulmonary artery. This is going to the lungs. And this is what's called a saddle embolus. It's sitting on there in the two vessels heading into each lung. There's no blood flow through the lung. This usually, they don't survive. Okay, and it happens in the hospital. They usually don't survive. Usually, what happens, like, you'll coat them, they'll come back for a second, and then boom, back down, coat them, back down. Okay, there's just no oxygenation of the tissue. This is where you bring in the TPA, and you try to break it up as quickly as possible. And then lastly, we've talked about inflammation. We talked about, complement kinin and all this. And, the big problem here is when we start to deposit too much. You get into something called DIC, disseminated intravascular coagulation. We use all our clotting factors. We clot up everything, and then we start to bleed after that, okay? This is, this could be frostbite. This could be black plague. But either way, this tissue is done. Right? There's really no coming back from that. That needs amputation. If we don't amputate, there's necrosis, and it just keeps on spreading and spreading and spreading. All right.